Hello and welcome to the Department of Respiratory Medicine at West Hertfordshire Hospital's NHS Trust for the endoscopic ultrasound training video. This next case was a referral from our breast oncology team for a 75-year-old patient who has an enlarging left adrenal mass. We will perform an EUS-FNA of the left adrenal gland.
Nice.
There we are.
Well done.
That's the hardest
well
bit.
Done. Okay. So the echo endoscope is placed approximately at 39 centimetres. And there's a very nice image coming into view where we can just see, if I can get my arrow, where's my pointer? Oh, here it is. Coming in towards, this is the intrahepatic portion of the IVC, the inferior vena cava. So the IVC is up here towards the
And that's the right
atrium. Yeah, it's lovely, lovely images there.
So right atrium, tricuspid valve and right ventricle.
Tricuspid, right ventricle there.
Okay. And a little bit of pulling out and manipulation
Now
gives us now we've got the business end of the cardiac structures, the left atrium.
Left atrium.
Mitral valve.
Mitral. We can even get a view of the chordae tendineae there, and then the left ventricle.
So there's the aortic valve en face.
So this is in cross-sectional view, that's in longitudinal view.
So that's cross-sectional, that's longitudinal.
That's longitudinal. And then when you're in cross-sectional view...
So if I stop there, we've got some important structures. So we've got pulmonary artery, where the arrow is, left atrium adjacent to it on the left-hand side, and aortic root underneath.
Beautiful views.
I'm slowly going to pull out, keeping the pulmonary artery more or less there. So there's nothing in station 7. So station 7 would be above the pulmonary artery.
Right.
But there isn't anything there. Could you give a little bit more midazolam?
Sedation.
So I'm getting air artifact now. So
presumably that's beautiful. You did it so quickly and so expertly that I missed you.
Sorry. So as I was pulling out, we've got air artifact, which means it tells me I'm at the carina.
The rings of the trachea.
Yep. Getting it's reverberation artifact, isn't it?
Yep.
And then clockwise rotation.
Sorry, Andy.
Drops me into the aortic pulmonary window. So there's nothing there. So we've reviewed station 7 and 4L.
And yep, absolutely.
Okay, just giving a little bit more sedation.
Well done. A little bit on the light side.
Excellent.
That's it. So we're just going back to roughly 40 centimetres. We've got the hepatic structures.
So these are very nice views of the left lobe of the liver. IVC there coming in, and then the intrahepatic portion. So there's the intrahepatic portion there. So if you were just to push in very gently there. Okay, there's the intrahepatic portion, and in fact, if you do a little bit of anti-clockwise torque, there you get a fleeting view of the liver hilum. There. So if I just freeze that and just go back, we're getting views of the liver hilum here. Intrahepatic portion of the IVC, this is inferior, this is superior or superficial, and this is deep. So this is the tip of the scope up here and the near side of the scope here. This is where your FNA needle would come. So IVC and the portal vein confluence. And this is a snapshot view of the common hepatic duct in longitudinal view. So this area is the left lobe of the liver and the porta hepatis.
Okay, thank you.
Very, very nicely done.
So what I'm going to do now is go looking for the aorta in longitudinal. And really, that's just
liver hilum there. Yep, beautiful view there.
Just actually, that was only about 30-degree rotation. So
Clockwise.
we've got the celiac axis coming off there, haven't we?
Can I make this a little bit bigger for a second?
Yeah.
So we'll just take the focal plane up a little bit. So the first vessel coming off is the celiac artery there.
Yep.
And then we have the SMA, superior mesenteric artery, coming off here. And then we've got another vessel coming off here, which is the left renal vein in cross-section. So celiac, SMA.
And then a left adrenal.
And then rotating clockwise.
Indeed. So that was about another 25 degrees.
1 degree.
So that was it.
Very, very expertly done.
And we've got the kidney
I might
underneath.
just make that... Can I get tissue harmonics there? No. Okay.
22 gauge standard, please. I'm just going to sit the scope there.
So I'm just changing the focus set back to just one focus set.
Yeah.
So left adrenal here. So this is quite a big mass lesion.
Thank you.
So I guess size-wise, this is at least
Just threading
20 millimeters in cross-section.
Sorry.
So, thank you. Okay.
Do you want the writing left on?
No, clear it. So
Okay.
just
There we go.
okay. So we're going to just gradually introduce the needle now.
Lovely. Very nicely done.
Sorry, Will.
It's all right. What is the other part? Just there.
Can we have suction, please?
Why are you laughing?
So, I mean, normally this is a gland that is millimetres across.
Yes.
So to have one this size is, unusual, worrisome.
I think the other thing to say about the left adrenal is that for those centres that don't do endoscopic ultrasound, they may look at it on the axial views or the coronal views and think that EUS will never be able to see the left adrenal.
Yeah.
But in fact, from the cardia so high up, and we're talking about 39.5 centimetres, it's lying right underneath the gastric mucosa.
Yeah. It's just
So it's actually a very,
very
very easy, accessible lesion to get at.
And generally speaking, EUS is well tolerated.
Very, very well
You're
tolerated.
You're
for
not in the
yeah,
airway, so the patient is not compromised in the same way they are with endobronchial ultrasound. Oh, beautiful.
Beautiful views.
So, interestingly, I made that, but I don't think I
Yeah.
made those other speckles.
No, there were some speckles before we started.
Yes, there were.
That's not calcification, is it?
Well, it can be calcification. We don't often see that, at least on the cases that were referred on EUS. One thing I liked about your technique and I think you both have demonstrated this in your tissue acquisition, is that when you've finished your EUS and you finish the last agitation or to and fro pass, before you take the whole needle out, you actually close the vacuum, but you don't release the vacuum until you take the syringe off. And I think that's a really good point, is that the reason why we want to remove the vacuum is that before we withdraw the needle out, we don't want a vacuum that's going to encourage contaminants and further tissue acquisition of the mucosa or the mucus inside the gastric lumen. So I think the message is to do exactly what you're doing, to close off the vacuum tube, but then take off the vacuum, disconnect it.
Yeah. The other thing that I think is really important in terms of ultrasound examination is remembering this as a linear ultrasound. So you're seeing one plane of the structure.
Yes.
And you can't understand its three-dimensional characteristics unless you fan or plane through from one end to the other.
Yes.
And to do that, you have to rotate your wrist and fan all the way through.
Yes.
Sorry, Andy.
Sorry. And hitting a moving target is
yes. So what is it? Oh yes. Yeah.
How was that?
I might take
nice
this off for
core
a
tissue,
second.
micro core.
Don't know which you prefer. Tissue harmonics on, tissue harmonics off.
Fair off.
It gives you a different view, doesn't it, and a different appreciation, I think.
So is that's with
Tissue harmonics off.
and then show me it on again. Oh, that's very
Oh,
dark.
I don't know what I did there. Hold on. That's off. I'm not quite sure what I've done there.
Okay.
That's both off.
We can live with it.
I'll take this up again.
The important thing is the needle is beautifully visualized.
Yes,
so
yeah. And again, just in terms of trainees, there's the tip of the needle, and the most important part of this whole needle to visualize is the tip, so that we keep within the area of interest. That's good for safety, but it's also good for tissue acquisition because it tells us that we're exactly in the place that we need to be.
Yeah, it's a bit more mobile. This. Often do you find this sometimes with sort of gut peristalsis and
Yes.
and muscular contraction, the target becomes mobile.
It becomes mobile, and also as we push the needle out, we actually push the gastric wall away, and then we can get a poorer view. One of the things that I think we've discussed in a previous case is to actually for an additional endoscopist or the nurse at the head end to be able to just hold the scope and apply just a tiny amount of pressure going in, not to push the scope in, but just to brace the scope as you're doing your twos and fros or your agitations. And that's a very good technique to be able to keep the lesion in good view.
Yeah. Okay. Thank you.
So we've got diagnostic material on first slide, so it's all going to go
Fine, great.
for cell block now.
It's a different quality of image now, don't it?
It is, and I don't quite know how I did that. Hold on.
We'll just turn the gain up now.
Have you? Yeah.
That's all right.
I don't quite know how I did that.
So it almost looks normal at that end.
Yes.
And then
yeah. And then you turn away and
you
then
track it around, and actually, just in case that is calcification, which suggests it's probably been there a long time, I've deliberately avoided
yes,
the area of
Mhm.
calcification.
So just for the training aspect, this is the gastric wall here.
Yeah.
This is the muscularis propria of the gastric wall. And we've got the left adrenal as we've discussed. Now deep to the left adrenal, so further down, we actually are hitting a structure here which is called the left kidney. And then superficial to the, so just to finish on this, the tip of the scope is here. So to be able to see the left kidney, you would push the scope in.
Like that?
you exactly like that, and you get a good view of the left kidney.
Characteristic ultrasound.
And then to look at the structures which are superior to the left adrenal, up here, we would have to pull the scope out and probably rotate a little bit clockwise to see the spleen.
Okay. Well, we can perhaps do that.
We can do that as you
once we
finish if you want.
Okay.
So, just to review, we've examined the liver.
We've seen the left lobe of the liver.
We've seen the main cardiac chambers and valves.
Yep.
We've tracked the aortic route up.
Yep.
And assessed station 7, which was clear.
4L.
At one point, whilst pulling out the scope, you get air artifact or reverberation artifact, which tells you you're at the carina.
Yep.
And a little bit of anti-clockwise rotation then dropped us into station 4L, which was clear.
Yep.
We then went back to the liver. About 30 degrees of clockwise rotation dropped us onto the descending aorta.
Yes.
We visualised the celiac axis and the SMA.
Yeah, which is beautifully done.
And then a tiny bit of clockwise rotation in between those two, the celiac axis and the SMA, led us to the enlarged adrenal gland.
And I think sometimes as endosonographers we focus on what we see, but it's also helpful to document what we don't see. So on the
Could you hold the scope for me?
On the minimum views that we've had of the left lobe of the liver, we've seen no lesions, we've seen no evidence of metastatic deposits. The other thing in the intra-abdominal compartment is we've seen no ascites.
Yeah.
So that's also very helpful. It's all part of writing that structured report when we report back to our stakeholders, to our referring consultants.
Tony, I guess as ever the comment or question is how much is enough?
Yeah. Okay. Yeah. Well, let's see what we get from this pass, and then reassess.
All right. Okay. Nearly done. Nearly done.
A little bit on the mobile.
So well.
Yeah.
How many passes is that, Winnie, so far?
The one that's going to give me now will be pass 3.
Okay.
Just try to take some slow deep breaths in and slow deep breaths out. Okay, focus on your breathing for me now. Slow breath in, slow breath out. That's better. That's much better. Slow breath in, slow breath out. Focus, there's a little bit of tension here. Just drop your shoulder. Just that's much better. Just allow your shoulders to relax. Feel that tension across the muscles at the back just to relax. Okay.
Okay, needles away.
Are you doing another pass?
Well, we'll see. I'll take Tony's steer. So,
Yeah.
if this is reasonable, do you think we can stop?
I'll have a look, yeah.
So one of the things that we've noticed in our institution is pharyngeal anaesthesia only lasts a finite time.
Yeah.
And one of the things that we can do sometimes, if the case is going on for longer, but we do get someone who's a little bit agitated, is pull the scope out and spray the pharyngeal anaesthesia on the shaft of the scope and then reinsert the scope.
Do you find that works?
And it really does, yeah.
Uh-huh.
The facility is that you get the local anaesthetic exactly to the place that the scope is touching.
Yeah.
It's never been published, it's never been documented, and yet it's so effective.
I quite often spray the scope first,
Yeah.
even before the start. But
I think it's a very, very helpful technique, particularly if someone is showing signs of becoming slightly agitated. Because sometimes they're comfortable otherwise, they don't need more sedation, but they do just need a little bit more
how's that looking?
local.
Otherwise it's good. In the back.
Yeah, we just need to see if it's just blood or whether there's some solid material.
Yes,
You have some solid material.
I think she
Yeah.
probably wants me to start.
Let's see. There is there?
Or fragile.
Let's have a look. Down there.
A few ones.
Yeah, there's a few worms. To be honest, if you can get one more, are you there?
Yeah, yeah.
Yeah, that's fine.
Get one more?
Yep,
One more would do.
One more on the finish.
Okay.
She's settled down again. Thanks. Thank you. Okay, last biopsy and then we're going to finish. Give me 2 minutes. Get that sheath
That's it.
out a bit longer. Sometimes helps kind of splint the target.
Nice. One of the things that you're demonstrating here is that you can sample through different trajectories
Yeah,
or fanning through a lesion of interest. That's very nicely done.
trying to. Just rotating it around a bit.
This is real world EUS with sedation. That's very nice. You've almost gone through the entire central body.
Okay. I think that's probably enough.
Very nice. Very, very nicely done.
Okay. Thank you. Thanks. Was there anything else you wanted to have a look at, Ray? Whilst
No, I think
Should we-
I don't think so.
Right, okay,
You could,
we're going to come out now.
yeah. So we've got aorta pulling out. We've got spine behind. Trachea, and then we're coming out. Perfect.
All done.
Well done. Well done.
Hello, my name's Andy Barlow. I'm one of the respiratory consultants here at West Hertfordshire Hospital's NHS Trust. The point of making this short video here is to demonstrate that this is absolutely a team effort. A complex endoscopy requires everybody to play their part. So I'd like to first of all thank the endoscopy nurse team who are scattered around here in the audience. I'd like to introduce the pathology team.
Hello, I'm Winnie Tang. I'm one of the senior biomedical scientists. I make the slides for the pathologists to look at.
And I'm Dr. Tony Maddox, and I'm the pathologist that she makes the slides for.
I'd like to thank my endoscopy colleagues.
Ray McCrudden, gastroenterologist from the Royal Bournemouth Hospital. I do endoscopic ultrasounds, not EBUS, but I'm very flattered and grateful to be asked to be part of the teaching and training today.
And
thank you. I'm Rahul Mughal, one of the chest physicians, works at Watford General Hospital, West Hertfordshire Hospitals NHS Trust, and as my colleague Dr. Rahul mentioned, this wouldn't have been possible without the teamwork, and that involves endoscopy staff as well as pathology and Dr. McCrudden coming all the way from Southampton. Thank you. Bournemouth, sorry.
So once again, a final thank you to everybody for a fantastic day, and let's look forward to the next training video.